invite our moderator, Nahid Fartahi, to introduce her panelists. Nahid, come on down.
Lunch was great, right? And it takes a while to regroup after such a nice lunch. And the weather is so beautiful outside. So I'll start like I always do. Let's start with a deep breath in and out to just regroup ourselves and bring ourselves to the here and to the now. When I was invited to lead this session on AI and mental health at Think conference, I felt both honored and very reflective. This opportunity is more than just exploring cutting-edge technologies. It is about bridging the transformative potential of AI with the core of mental health. And core of mental health is compassion, it's connection, it's humanity, it's human connection. As a psychotherapist, I know the value of making people feel seen and heard. But with AI playing a very growing role in healthcare, we face a very crucial challenge. How do we ensure that these tools, AI, enhances, not replace, that human connection, that human empathy? And today we will explore how AI can support therapists, promote cultural inclusivity, and expand access to care for all. And to realize this potential and collaboration, I'm here with some very esteemed colleagues and fellow mental health practitioner and therapist from my field. I'll introduce to you Dr. Aishwarya Joshi, an assistant professor at the University of Vermont. She's a licensed and board-certified counselor in the US and in India with decades of global experience. Her work focuses on ethics in AI and counseling. Welcome, Dr. Aishwarya. Next is Dr. Mansi Rana, a Stanford graduate, psychiatrist, who specializes in child and adolescent psychiatry. She teaches as an adjunct associate professor here at Stanford and works at Kaiser Permanente. Dr. Rana integrates AI-driven tools with therapy and medication management to enhance patient care. Thank you. Welcome to the stage. Last but not least, Dr. Sinika Gaynor, an assistant professor and clinical director at Jacksonville University. She has nearly over 20 years of experience in counseling, education, and supervision. She owns a private practice, supervises emerging professionals, and works as a content leader for Inner Peak, which works in AI and counseling. Welcome. So, Dr. Rana, I know that you have a little presentation for us to kind of go through, not a presentation, but rather more of a visual aid for everyone here. Here is the question. AI-ascribed technology and applications, right, has rapidly emerged as a very valuable tool in healthcare, right? It is automating documentation and streaming administrative tasks, which is very tedious for those of us in healthcare. We're very aware of that, right? However, its purpose is not to replace clinicians, hopefully not, right? But to support them and enabling more time and focus on patient care. So the human element remains a very crucial and very critical part of this. And here is the question: how does AI scribe technology could enhance clinical practice while still emphasizing, and I focus on this word, emphasizing the role of a therapist or a psychiatrist?
So in my practice, we have rolled out Scribe technology for the past year and a half. So we had Nabla before, and now we have another platform. What I have seen is that over this time, when the scribing happens, it pretty much notes down every single sentence said by me and the patient. And then it generates a note. So most of the scribing has started with medical models, so like for primary care physicians. So it's very much bulleted. It started off by being very technical, but in the mental health field, it's more nuanced than that. There's a story a patient tells you, and our appointments are like, at least my intakes are anywhere from 1 hour to 2 hours, depending on the complexity of what's at hand. Over time, I have realized that the LLMs have picked up. They've picked up so well that they are actually able to say the story in how I am talking to the patient, and then generate a very comprehensive note. So that's what I wanted to show you, but I don't think I can get it up here. So I have about 18 or 20 pages of a transcript that now got shortened to 3 pages. So what it allows me to do is really just look at the patient, talk to them, and not be typing my note. So that patient to doctor connection, that eye contact, understanding their story, and that is just a different feeling altogether. And all of us, are used to the industry, right? Patient satisfaction. So from like doing average, I've gone up like at, very, very high, where patients feel heard, they feel like I'm connecting, I'm following the story, I'm not focused on note writing. So that's been very helpful. Another thing that has been helpful is when, for example, when you're talking to a patient, like those in medicine would know, it could go anywhere. You might ask a question, and then because something else came up, you pivot, and you forget that that one thing also was important. So when this AI is generating a assessment and plan, it will pick up. For example, if I've spoken to a patient about like, okay, you are on this medication and your blood pressure is high. What do you do? So I just mentioned it, and then I forgot because I was talking about bipolar disorder or PTSD. But in my assessment, it picks it up and it brings my focus back on that this is one thing I don't want to miss also. So AI has been, at least the scribing part has been a game changer for me. Um, I also look very smart on the note. So when I'm asking questions and the AI is able to actually, for example, those of us in medicine, we talk a lot about, patient is resistant to therapy or non-compliant. Those words can, and now that all of our notes are open, those can be very jarring for patients to see, like, this is what my doctor thinks of me. But now with AI, and that has been trained to be more, what should I say, politically correct, I think it enhances patient-doctor relationship. It has.
Wonderful. And do you think that, we are a very diverse world? Does that account for diversity as well? Meaning, sort of one patient may describe or their presenting problem in a way that it's sort of culturally different than another person. Do you feel like, is that picking up on those nuances and those delicate parts as well?
I think not, that is something that an LLM can be trained. And so if we see diverse patients and if we are using translators, for example, or interpreters, then yes. But then again, I think this is all about training and feeding in that information. I'm sure that that'll happen. But again, back to your point, it doesn't take away the clinician. So for example, I had a patient who's telling me about their problems, and then I'm asking about family history, and she says, "Well, my mom had bipolar disorder." I said, "Like, how do you know?" "Oh, she would talk to spirits," and this was but this was a person who grew up in South America. So I'm like, okay, culturally, do you think this was inappropriate or was it appropriate? So, well, my grandmother also talked about spirits, but when she would say things like, I can feel them protecting the family, versus my mother who was having a conversation with. So it still needs some direction. So I think if as we expand our database over time, it should AI should be able to pick on these things.
Yeah, thank you for that answer. And kind of going back to you, Dr. Joshi, I know that you work both in India and you see patients in India and here in the US. How do you, what are your thoughts on this topic and the question?
I do believe what Dr. Rana said as of right now, that while transcribing supports and adds to the efficacy and efficiency of a clinician, a big piece of that is also recognizing language. Like, for example, and I'm going to give this example in context to being a counselor educator more than a clinician. When we work with diverse students who come from different parts of the world, whose first language may not be English, and contextually within the US institutions where English is your oral language, especially within the field of mental health, the scribe technology actually helps them clarify their thoughts in English and help them present what they're trying to articulate, because it takes a lot of mental toll and taxing to speak, articulate, write in a secondary language. And I think that is also true when it comes to counselor-client relationship. If I'm seeing a client whose, let's say, primary language is Marathi, having a transcribing tool that allows me not just to say what I'm saying while it's transcribing, but also show them. So it's oftentimes, it is not just the words that I'm speaking, but a written part of it, that transcript that allows them to say, oh, this is what I'm trying to say, giving them that opportunity to reflect and pace instead of just having a one-on-one dialogue.
Okay. And so is it transcribing in other languages as well? Or in the languages that you provide?
In the language that we provide, because once again, this refers to what language you're feeding to the AI tool.
Okay, yeah, wonderful. And I know, Dr. Kaina, that you do a lot of supervision as well and consultancy. Have you used this in that work with your supervisee people, essentially the next generation of mental health clinicians?
Absolutely. We are all using AI, right? We're all using it, even if we're not trying to use it. Do we have any Amazon shoppers in the room? We're using it. Anyone watching Netflix, we're absolutely using it, right? The machines are learning what we like and giving us suggestions on what to buy next or what to watch next. And so even with my students, with my clients, we're definitely using AI. The importance is informed consent on how it's being used. And I think I agree with my fellow panelists that these are critical concerns: privacy risks, algorithmic bias, and lack of transparency. All three critical concerns for AI. These concerns also parallel the concerns we have for mental health professionals. We talk about these concerns when training counselors, right? We want them to be transparent, use beneficence and non-maleficence with their clients. We train counselors to be mindful of their bias, systemic and personal, when working with patients, right? And so the concerns we have with AI parallel the concerns we have when training mental health professionals, which means that we can future-proof the profession and get ahead of this and teach the AI systems what we want it to know. AI systems are as unbiased as the data it's trained on.
Okay, yeah, thank you. This takes me to the next question, which is about the ethics. Ethics and privacy. How do we make sure to work with the technologists, right? Because, I mean, I'm a mental health practitioner, not a technologist. And I know that AI is a very growing field, and it's already, as you all mentioned, a part of what we do every day, making our jobs easier in many ways. But a huge part of our jobs as practitioners, especially mental health practitioner, is the confidentiality and the privacy of the patients that we work with. So how do we ensure that? How do we work with the technologists who are making these magical AI happen to work with our magic and combine it together in a way that would make sense for our patients, for our clients, essentially?
So I can just tell you what we do. So almost all patients know about the scribe technology and that we use it. But each time a patient comes in and I'm switching on the recorder, I say, are you okay with me using the scribe? And sometimes they say, no, I've had that, then we don't use it. And most of the times they say yes. And part of their documentation in the chart, every single note is, patient consents to AI scribe. That's what we've been doing.
So you are asking each patient whether.
Yes, as soon as they come in and before we start talking, I ask them for their permission. And all of this is approved by by Kaiser. I work for Kaiser, I see patients at Kaiser. So it's not like any AI tool. It is the tool that has been, that's HIPAA compliant and that is embedded in our charting. So it is not any random tool. And every time a patient comes in before starting, I ask them.
So as you were just explaining that, a huge part of becoming a clinician is all the board exams that we go through, and one is the law and ethics. And I do foresee that they would add consenting to AI in your practice as a ethical and legal code. I hope in the future it will be a part of it if it already is not. Right?
We had that issue come up. So as part of my educational endeavors, I also teach Q-centered therapy to therapists who are sitting in different parts of the world. And this course spans months. And at the end of the course, everybody has to generate a report or the assessment and case formulation. And we were taken aback that two of the therapists had this perfect AI generated report, and we didn't have a policy around it yet. So it's feeling like, we're just catching up to where the industry's already gone. I think not just mental health, medicine in general is, it's one of those frontiers where it's harder to just implement things because it is so personal, especially when it comes to mental health. So I think that Stanford has a policy, but we in our department didn't have this, we didn't elaborate on it, but now I think we've moved.
Okay. And what would you say, what are some of the boundaries that should be protected in this field when AI is used and incorporated into our daily practice as clinicians?
So I think it's important, one, to recognize that even prior to AI, within the field of mental health, we talk about confidentiality and privacy breach. And I think the one big limitation of AI and integration that a boundary should be made is around how much of are we using this technology as a support. And I'm talking about in specific context to, let's say, when you're working with high-risk population. Somebody who, and I'm going to give an example of somebody when doing a suicide risk assessment. When someone is at a very high risk of suicide, AI generative tool is not going to be helpful. The humanness, the human therapist needs to be there present. And an AI, as much as it's generative, cannot differentiate between a suicidal ideation versus an actual act of somebody completing suicide. So there has to be very clear language around the limitations of AI in any ethical policy that you make, whether that's policy as a clinician, whether that's classroom policy when you're training future clinicians. It's important to remember that there will always be limitations. We talk about cyber attacks and security breaches. These are one of those limitations that has to be mentioned in addition to how to use AI ethically in a policy statement. There is the other piece of gap between making a policy and actually implementing it. And as professionals, especially mental health professionals, it is important how we train the next generation to ethically implement the use of AI. So for example, when the pandemic hit, especially within the field of mental health, there was a lot of resistance towards telemental health. And the pandemic resulted in a sudden overnight change of seeing clients through telehealth. And those ethical practices of how we use telehealth specific to mental health had to be integrated in the policies immediately. And that also comes with limitations with client confidentiality and privacy. So the boundaries that you're talking about has to be not just written, it actually has to be implemented by trained professionals, whether that's a supervisor, whether that's a counselor educator or a mental health educator in any setting.
And going to the example that you give, which is so very important, the crisis, right? When it comes to crisis, can AI, and people we know that do use AI in order to, Dr. Google is a thing, was a thing, and now we could say there is Dr. AI. I'm gonna go type my problems and hope that I'll receive help. When we are talking, Dr. Gaynor, about crisis, we can teach AI, can we teach AI empathy, but how can we teach AI compassion? So then AI can compassionately, right? Without the, and this takes me to the next step. How can we teach AI compassion so then people are not putting themselves in complete danger, and people know that AI can never really replace their therapist, their psychiatrist?
Sure. Yes, AI cannot replace the human touch, for sure. We can teach AI empathy and the language of compassion, but we can also teach AI to direct people back to the professional. And the way to do that is to ask, what is the difference when I am developing a therapeutic alliance and at my core as a mental health professional is empathy? What's the difference in my language, in my personal touch, and what AI is generating or what ChatGPT is saying to a client? And it's the processing. The change happens in the process, not the intervention. AI will give all of the interventions. Social media, Dr. TikTok will give all the interventions, right? It'll tell you to journal. It'll tell you to go for a walk. It'll tell you to do all the things. The clinician comes in to actually process the issues, process the statements, so that when the statements come from AI on compassion and empathy, yes, it's saying the language that we're using, and we come in to process the things. For example, I've had clients say, while I was away, when I didn't see you, I asked ChatGPT about my depression, and it had me think about these questions. And they were reflective questions that I thought were wonderful. Go ChatGPT for giving these questions to my client, but she wanted to talk it out with me. And that's where there's the nuance that we can teach the learning machines the language of compassion, right? But it can also redirect a client to the person who can help with the processing and then for the expression of the compassion and empathy.
Yeah, thank you for that. And so kind of going back to the technology aspect of this, I think we talked a little too much of like mental health lingo here. Going back to that, right? The integration of AI and LLM, we have talked about it so far, how it is essentially reshaping the future. And this reshape has started it already. And we said that, yes, these technologies can create and offer personalized tools and learning paths and sort of like even virtual patient simulation and sort of advanced diagnostic aids using the cultural diversities into consideration. So despite all of these advancements, the four of us are still sitting here and saying the role of therapists, the role of psychiatrists is still as important, if not more, right? And so, and on a note on the emphasis on human connection, the ethical consideration, compassion, and empathy, which are paramount to this topic. I'll start with you, Dr. Rana. In what ways are AI and LLMs will transform medical therapy and psychiatry education to create the new generation of mental health practitioner in the 21st century?
That's where we are all, I feel like, so old, because all of the medical students, residents, and fellows now have access to, not all, like majority of them have access to scribes, AI scribes. So whatever questions they ask, they get an assessment and plan. So there's little emphasis on, note writing or understanding what question to ask. So and so I think that's one of the challenges I face. I've been learning very quickly. I've been attending courses and figuring out how to create case scenarios with these complexities through AI for the residents. So I'm able to, generate one slide that I've asked, for example, generate a case report on a 35-year-old presenting with irritability and anger. And then I give it another command like, patient is resistant to talking. Patient also does not want to see you, and that there's significant family history of bipolar disorder. So so as I give it directions, it generates a case, and I can modify it as we go along. And there's technology out there where this could be a person who talks. So it is, a bot that's talking to the resident, and they're playing out a scenario. So it's labor intensive for a person like me because I haven't been doing this all my life, but I think that our clinicians of the future will be doing it. So that is one way we are using it. Another way of has anybody prepared like PowerPoint slides that take hours and hours? Oh my God, I would spend like, if I'm teaching a course, I spend like 4 or 5 hours just creating about 20 slides. And then one day, once I got whiff of AI, I just asked Perplexity to generate, a presentation and examples. So I just gave it commands and boom, I had like 20 slides. And then I said, no, cut it down to 10. Game changer for me, for sure.
Yeah, none of us, I guess, got into this field to write notes and to create presentations. What are your take on that question? Where do you see the next generation of MFTs, psychologists, counselors?
I believe it will actually help bridge a lot of gap that we have in the mental health profession for the professionals. For example, within the USA, the mental health gap for a patient or a client to a professional is 1:400. That includes psychologists, social workers, LMFTs, you name it. So with an AI bot, let's say, it will allow to bridge that gap between when a client sees a mental health professional and then there's a wait period and a time. So, for example, my client saw me on a Monday, and my client comes up with they have a history of trauma. We are working on trauma-based interventions. Now they see me the following Monday on a weekly appointment. And in between that time, another crisis happened. What are they going to do in between that time? Because they won't see me till next Monday. And how will a bot in this space allow them to ground themselves, help them almost like form a falling cushion for them in the meantime when they see me again, so they are more regulated emotionally, versus when you don't have a bot technology to address these gaps. Another thing the pandemic showed is the dearth of mental health professionals in the field, and how there were waiting lists of like six months for potential people to see mental health professionals. And I think having an AI bot or technology would allow to bridge that specific gap, that there aren't enough professionals who are seen. And this is not just limited to clinical field. I'm also talking about mental health professionals who work in school settings, who are often have a caseload of like, let's say, 600 to 700 students. And having a bot there to help mitigate some group work while they are waiting to see the individual school counselor, let's say, that can be mitigated through a bot.
Wonderful. And that takes me to a very important part of this discussion. And that's, how do we ensure, and you can take this question if you like, how can we ensure that this technology is expanded so we could serve our underserved communities?
You know, I'm not so sure about the word ensure.
Mm.
Right, we can try. I think that training the next level of counselors, MFT, psychologists, and the like, we can train them to be mindful of, like I said, personal and systemic bias. Think of AI as a tool that will increase accessibility for clients in rural areas or families that are always moving, military families and the like, so that we are extending our reach as counselors. I think the same effort that we put into developing mental health professionals to be mindful of confidentiality and informed consent and constant development is the same energy we will have to put into these AI tools. It will require monitoring. It will require teaching and training of the tools so that we're constantly mindful of an evolving landscape. We don't know what this is going to look like in 10 years. We don't know who's going to have access and who isn't. And so remembering that we're the ones teaching the systems, the machines, is important, right? We can future-proof this by getting ahead of it, training the systems on what we want it to know, training those who are working with the systems, and then also trusting this next generation where technology is their framework and it's their lens, right? I'm sure there was a lot said when the computer was first developed, or when someone had to put down their floppy disk and start saving things on a cloud. And you're like, where is my data? Where is everything going? This has always been the conversation when things change. And I think we are uniquely positioned as mental health professionals to come alongside millennials and Gen Z, where AI and tech is their framework.
Nahid,
Yeah.
what you said or you asked is something that I've been thinking for a long time. And I think this may be a good place to pitch this idea. So I worry about, we worry about mental health professionals and availability of help here. Look at the whole world. So that's why I've been very interested in teaching, training as many MDs, as many therapists as I can, who can then work And what I'm thinking now is how can I use AI to provide that something in the field. So I have a cousin who's sitting in India, and I've asked him, like, can you help me figure this out? Like, how can I use LLMs to create something? And so I don't know. I am still thinking, because that's the question. How can we teach AI to become a clinician, to be able to ask the next question? Because even today, there's a big difference, between a new trainee and somebody who's been in the field for 20 years. Like instinctively, okay, this is what the patient is saying, this is what they're coming across, this is what probably is going on. But if we can't do that 20 years, if an AI cannot look like a 20-year-old professional in that field, can it at least do a basic workup? So I'm looking for ideas. If anybody, please reach out to me. I really want to work on that.
Thank you for that. And what a wonderful sort of ending to our discussion. But we do want to open to the floor to questions and answers.
Dr. Rana, have you looked into, what is your thought process for the inpatient psychiatry? For the patients who are in, who come for a short stay, and then do you think that AI is something that could be used for those where the notes and other things are being taken? I mean, so where you have to take care of like every 15 minutes, some mental health tech is reviewing it, or nurses are taking the assessment and it's not being done by the physician itself, so there are multiple people coming in, and where the medication management is more complex, so in the inpatient settings. What are your thoughts on?
Inpatients, their patients are, there. And there's not, so when you talk about, using AI, I'm thinking, are you thinking, as you were asking the question, I was wondering, like, maybe not the note writing stuff as much. Sure, we can, each time they talk to the patient, they can have a scribe. Where it might be useful would be bringing in the data from their outside providers for that one incident that they're in the hospital for that psychiatric episode. You see what I'm saying? Like somebody doesn't have a history in that particular hospital, but they've been hospitalized elsewhere, different diagnoses, different plans. So to get that comprehensive data is one place where I think that might be useful. But yeah, I don't know, were you thinking something else?
You need consent, right? So where when you're providing psychotropic drugs or what have you, and in that case, do you think that AI is something that can help?
If somebody,
PRN medications, so there are a lot of things that go on with the patient when they are in the inpatient settings.
we're not there yet, because you need consent from the patient for any medication unless, you have a court-appointed, person taking, making those decisions.
On the mental health side, somebody needs to look at, and that is the inpatient settings. And it seems like whenever we're talking about mental health, it's primarily on the outpatient settings.
Yeah. That's a very specific population, like, but yeah, like, I don't want to take too much time. I know there's other questions, but there's, I still remember as a resident, there was this one patient who was manic, and I was a resident, and my professor, who's been on call the whole week, I'm calling because everything that was a PRN had been given, and we still couldn't do anything. So if you're asking about, like, will AI tell you this is when you give this PRN and this is when you add something else? I think that would be very interesting.
We have time for just 2 more questions.
Yes. Hi, everyone. Thank you. My name is Nikon. This has been so great. And this is something I've thought about quite a bit, but I'd love to ask this panel here. And my question is essentially, as AI therapy can kind of be something that is more mainstream in a few years, you might say, well, are you at all worried about people's comfort with engaging with real therapy? And the reason I ask this, I've worked on chatbots in the past, and one of the common things that is often touted is that this was in the space of chronic disease management, but people oftentimes feel they don't have to worry about the sense of judgment when they're talking with an AI. And you could imagine that people maybe get more and more dependent on that relationship and fear the actual human connection that comes from therapy. And just in my own personal experience with therapy and with others, working through a little bit of that messiness and awkwardness is a very valuable part of that process that you described. And so I'm wondering if you have any thoughts with AI therapy being a reality, how do you still hold on to that other piece of that human element that could be very valuable?
You know, I think this client's story is where every clinician can and probably should start. And so I've had clients come in and say, I've been talking to a chatbot. I don't really see the purpose of this. And I would ask them to walk me through what they love about talking to a chatbot, right? I don't have to convince anyone that this is better. I just want to prioritize what they want to talk about. And there was a reason why they came. Eventually, we got to that, but they started off with, this is uncomfortable. I'd much rather talk to a chatbot. So when I'm training my students who have clients who are maybe experiencing some resistance, first we look at what are the underlying issues? There's always something underneath resistance. As you mentioned, it's uncomfortable to be in front of someone. That could be the real reason. I have a fear of opening up. That could be the reason, right? As opposed to having a solution to that or something to say that would make this better, I join them in their experience. What is it about the chatbot that makes you feel comfortable? What do we need to bring into this space that would mimic that comfort, or would make this a space where you feel comfortable being vulnerable? I think this is about joining as opposed to replacing or figuring out which one is better. I want AI to be an extension of what we do and complement our years of practice and education on it. I don't find it as something that we need to compete against. Just join people in the conversation. If you're someone who likes to post material on social media talking about this, that's something to talk about, that we're not in competition, right? But if there is a time where you're a bit stumped after talking to a chatbot, you can definitely come and talk to a person as we process what was said in the chatbot.
Hello, here. So a question for Dr. Rana or maybe other panelists regarding, I noticed that you're asking question regarding the family history. I was thinking that, is it supposed to help the patient or maybe the relatives just in case the family history is positive or any of these indication? And in your practice, the AI potentially can change the perspective or the landscape of getting this information. And what would be the next step?
So family history is an important part of history taking, medical, psychiatric, both. So there are many diseases like diabetes, high blood pressure that run in families. Similarly, there are many mental health disorders that run in families. So when I'm asking about family history, it is for that patient because that is the contract I have. This is our understanding. You are here and I'm here to help you. So family history, when I'm collecting in that regard, is only for that one patient. However, when we're talking about that and it comes up that there's other relatives that or sometimes patients say, no, I don't have this, and I'm diagnosing them with that. So no, I don't have bipolar disorder, but yes, I have this family history of ABC. Oh, I don't look like them. But eventually it helps them connect the dots too. I've had patients who have gone back to their sibling and said, you need to go see somebody because they describe, so sometimes patients may not say, my sibling has depression, or they may not word it. Says, no, I see her crying a lot. And when we start talking about this looks like depression, then they can have the ability, and sometimes when they will tell their sibling or their parent, I think this could be helped by a medication. So indirectly, there's always that possibility. AI can't go into telling somebody else something unless they are in the appointment. They won't go into that patient's chart, siblings or parents' chart and do their work. At least they shouldn't be, right?
So, hi, I am Deepak Subramanian. Thank you so much for this amazing session. I just a recent graduate from Master's Computer Science at University of Illinois, Champaign-Urbana. We have been doing this extensive research on LLMs in mental health. So we were exploring how we can reduce the session time in an effective way, because we know that for every 353 individuals, one mental health professional is available. So is there any way we can potentially reduce the session time per individual by bringing an additional insight? For example, I'm going to a psychologist, day 0 I'm going, and day 15 I'm going. What happened in between the sessions? Can we bring a heat map of an individual? Hey, Deepak has been low between January 5 and January 10. So if you know that before I step into that session, hey Deepak, do you want to talk about what happened on those days? So maybe we are hypothesizing maybe how the care would be. So we know for a fact the healthcare is also moving from fee for service to value-based care. Like, could it be this kind of intervention? So here we are not replacing, here we are not actually, doing something, removing the human touch, as ma'am mentioned. We can pull up all the what kinds of comments they are posting in social media, what they're talking about, summarize everything and give it to them. Hey Deepak, what do you want to talk about again? So what are your thoughts on this particular intervention? I'm just curious.
You can take it. Oh, sure. Well, here's the thing about the human touch that we kind of, and the compassion and empathy that we're talking about, is subjectivity versus generalizability. There is this piece of efficacy and effectiveness of AI bots to make things consistent so that there is a client, counselor, or therapist patient time is reduced. However, predictability can only happen when there's time given. So what I mean by that, therapeutic alliance is not built overnight. To build that trust and trusting relationship, it takes time. Vulnerability. You're talking about somebody sharing their deepest, darkest fear, thought, something they didn't even share to their family members or friends, and here are sitting in front of a complete stranger. Because that stranger provides the buffer of what, let's say, I would say, telehealth. People feel more confident saying things behind a screen typing versus saying the same thing upfront face to face, because that screen provides a buffer. Similarly, with AI, in order to build that buffer or in order to build that trust, it takes time. And I'm going to just give an example. My client is not just suddenly going to trust a bot map work of, okay, this could be predictability of these are some of the things that you may want to talk about, because a lot of times these sessions are guided by my clients and not by me. And I think that's where that nature of mental health professional and client relationship is misunderstood. I am not telling them what to do. I'm just walking by their side, helping them recognize that they have answers to their own questions. And bots can help definitely in reducing that time. And it's a both. Therapeutic alliance requires people to be there. Did I answer your question?
I'll add something else. If somebody is seeing you and they're very vested, they have a plan, we have to end. But what you can do, you have a session and you have another session. If you have come up with goals, they want some skills, how to calm themselves down when they have panic attack, you can give them skills. You can have a bot reach out and say, did you practice your skills? So you can have, that training going on for these little things. So when deep emotions may not be talked about, but these little things you can definitely add, and that data can come to you when you're seeing them. And then you can do the deep talk therapy at that time, and if that helps.
Let's give everybody a round of applause. Thank you, panelists. If our lovely panelists can leave their microphone, that would save me some calories. Thank you.